Professor Svetlana Vujovic, and she will talk to you about premature ovarian aging, a very important topic, and the role of micronutrients. Please, Svetlana.
Dear friends, colleagues, first of all, I would like to thank legendary Professor Genezzani, #1 in the world and really a great, great man who put us all together once again. Then thank you, Ashraf Irmani, great scientist who is dealing many, many years in this field. And thank you for the invitation, because you always know to find out something new. And you think that I will offer something new. I'll try it. Let's do it. Okay, premature ovarian insufficiency and micronutrients. The definition of POI was changed during aging, but it is oligoamenorrhea at least 4 months, with first FSH over 40, and it was our statement in 2009. Later on, ESHRE gave the definition FSH over 25, but in fact, I think all FSH levels above 10 or 15 will be in focus, because we'll earlier make detection of all these young women who are being menopausal, so very, very early menopause. Of course, we have to treat them because their future is very bad, not just for fertility, but for all other organs in their bodies, because hypoestrogenism will damage all their bodies. So we give all to them therapy, which is conventional therapy. At first, estradiol, which sensitizes and differentiates granulosa cells, downregulates FSH and LH receptors, increases response of FSH and number of LH receptors previously induced by FSH, lowers LH and prevents premature luteinizing of the remaining follicles, and during 12 months, some 46% of patients can ovulate in the very beginning of POI, so it is not impossible. And estradiol stimulates endometrial proliferation and production of the cervical mucus. But what about pregnancy rate? A year after the last menstruation, there was 1,000 follicles remaining in the ovaries. Great numbers, but many of them are not of a good quality. And very often you can hear all of them are very bad, you can do nothing. And it was a disaster for all these women with such a bad situation in their lives. But 75% of women with POI have potentially functional Graafian follicle, and inappropriate follicle luteinization prevents ovulation. But we found out that if we reduce FSH by adding estradiol in a higher concentration and having FSH below 15, then we can have ovulation even in those patients. And other studies confirmed something like that 3 out of 4 women with POI have ovarian follicles remaining, and even pregnancies in some of them. So Gu, in the last article in 2020, found pregnancy in women after 10 years of amenorrhea, but treated with estradiol and progesterone. And now let's go to the focus. Can we do anything? Or we can tell to our patient, your chance for being pregnant is 1%. So it's impossible. Please go for donation. But some of them don't like donation, and they are not psychologically prepared for something like that. So can we do anything to prepare or to make better all that oocytes and even endometrium? So biological age is not so important as is important, not chronological age, and optimal hormone environment. So we have to make optimum hormones. 248 hormones are secreted in endometrium. Do we know anything about them? Do we change them? No, never in our lives. So we have to think about that, as well as influences on the quality of the oocytes. As well, immunohematological balance is important and relaxing way of life. During oocyte development, cumulus oocyte complex plays an essential role in lipid metabolism and energy production. Energy production, I tried to think about antioxidants and anything which can be in correlation with something like that. Then maintenance of lipid oxidation with or without protection of free radicals is critical to preserve embryo quality. Do we think about that in everyday practice? Rarely. So we have to think about it. And antibodies improve, antioxidants improve oocyte quality. So we have to add them to the standard, normally, therapy for these patients. And natural or modified cycles with estroprogestogens represents first-line therapy in POI patients, not GnRH agonists, maybe only on the very beginning. And clomiphene citrate has no proven benefits, so we have just to increase estradiol. And then, what is the typical percentages and very different medications for these women? Estradiol, valerate, and norgestrel. Metformin, why? Because we tested a biggest group in Europe of 2,500 POI patients, and due to all of them, OGTT, oral glucose tolerance test, and see area under the curve, and found out something very interesting. They are mostly lean persons, not obese one, but they have higher area under the curve for insulin. Why? Because of way of life, because of stressful conditions, and because they are becoming menopausal, even if they are 18 years of age. Then we add to some of them alprazolam for relaxed situation, melatonin, vitamin D, and aspirin and methylfolate for some having thrombophilias, which we as well are testing for. But Proxeed is today in the focus. So I wanted to try what will be with all these patients in pregnancy rates if we will add Proxeed female to all of them once daily. And this is very well known formulation for Proxeed women, but not only for acetyl L-carnitine and N-acetylcysteine, folic acid, but vitamins. Why? Many women seeking for pregnancy are taking pills and many kinds of vitamins, 10 vitamin in a tablet. So can you imagine how many medications they have? Or it's much easier to put it in the water and to drink it. And Proxeed women have a multifunction ingredient system, but it increases changes of conception through all these pathways. So many pathways through vitamin ways and L-carnitine and acetyl-carnitine, etc. So what are biological roles of L-carnitine? And they are scavenger system for acyl groups, and they are anti-apoptotic, buffering of mitochondrial acyl-CoA couple. So we are not thinking about that, about mitochondria in POI patients, or maybe we are thinking about it. But I would like to stress it, to stress the changes on oocyte quality and endometrium quality because of reception of that embryos. As well, there are membrane stabilization and many other influences on cytokines, and all of that is a role of L-carnitine. So Proxeed women reduces effects of free radicals formed during cellular metabolic processes and be exaggerated in condition of an environmental and stressful condition causing damage. And all of these women are living under stressful conditions. Oral administration of acyl L-carnitines alleviates ovarian dysfunction, and co-administration of propionyl L-carnitin provides better activity of molecular mechanisms. It reduces cytoskeletal damage, reduces embryo apoptosis. Look at that one. Reduces embryo apoptosis. So you can't say you have a very bad quality of oocytes. Let's do something. Let's improve it. And it reduces DNA damage. Reduces DNA damage, increases energy, and stimulates blood flow. So we can do something with them. As well, mitochondrial carnitin pathway interplay between the leptin and glucose metabolism. And why is it interesting? Because I've mentioned you that many of them have higher insulin area under the curve, and this is interaction between Proxeed and this metabolism. Then it re-stabilization of proteins in the cellular membranes and their effects on gene expression by histone acetylation. So many, many actions. And L-carnitin defense of mitochondrial integrity. So mitochondria are better, even in those women having just a few follicles remaining. It's a regulation of enzyme-generating radicals, improvement of antioxidant defense system. So many, many actions. Acetyl L-carnitin exerts cholinergic effects and modulates the gamma-aminobutyric acid system. It plays essential role in intermediary metabolism, acting as a donor of acetyl groups, facilitating the transfer of fatty acids from cytosol to mitochondria during beta oxidation, and it improves mitochondrial messenger RNA translation. So it influenced genetic changes in that young women having very early menopause. And this is very well-known slides for sperm maturation, but as well for gene expression in women, and we can do something. Ashraf Rirmani made many, many studies, but here I put just a few of them, as well as my friend Alessandro Genazzani, who is working years and years on this title and team, and really they are the most important persons for me working on this field. So when Ashraf treated mice with both L-carnitin and acetyl L-carnitin, it resulted in increased number of mature oocytes and less oocyte degradation. So maybe it's the same in women. Then the supplementation of carnitins in 8-week-old female mice not only improve oocyte formation, but also increases the number of live births as well. Intrafollicular ischemia and hypoxia negatively influenced spindle organization and chromosomal segregation in the oocyte, so direct effects on oocyte quality. And Alessandro Genazzani found that carnitins are mediators of the action of leptin, ghrelin, insulin on NPY and propiomelanocorticotropin secreted neurons in our new journal GRAM 2020. So new data for POI patients. And what's correlation between carnitins and insulin? Acetyl L-carnitin improved hyperinsulinism in polycystic ovary syndrome, and we know for that. But at the same time, it can improve it in POI patients. Then there are improved expression synthesis of hepatic degrading enzymes responsible for 80% of insulin clearance. Other studies found L-arginine improves insulin and sensitivity in beta cell function of the offspring of diabetic rat. And carnitin deficiency can be related to the decreased number of oocytes in IVF cycles. So many, many new informations for all of us. What's about the radiation and POI because of radiation in some patients? And this is a study from 2 years before that it has protective effects against gamma radiation provoked premature ovarian insufficiency, when after that they reverse abnormal estradiol by 73% and anti-Müllerian hormone for 40% through upregulatory expression of eggs and suppressing signaling pathway. So women have a fear of anti-Müllerian hormone. If it's too low, they are depressed, and they even make all situation worse. So we can do something as well in this field. What about steroidogenesis? Transport of cholesterol from the outer mitochondrial membrane to the inner mitochondrial membrane by the steroid acute regulatory protein. But cholesterol is metabolized to pregnenolone by cytochrome, family subfamily A member, which is then metabolized in the endoplasmatic reticulum to form estradiol and progesterone. And now we are talking about mitochondria dysfunction and POI. Just a few works are about this story, and practitioners don't know much about it. Mitochondria are maternally inherited double membrane organelles with the role of a powerhouse of cell based on other generation of ATPase via oxidative phosphorylation. Mitochondrial dysfunction, poor oocyte quality. So let's do something and improve oocyte quality. And mitochondria influence OXPHOS, ROS homeostasis, apoptosis, thermogenesis, steroidogenesis, everything on the molecular level. And look at this scheme. Estrogen regulates many of the key enzymes involved in mitochondrial bioenergetics, including glucose transporters. So this is interrelationship between estradiol, glucose, and mitochondria metabolism, and something what we can improve in all POI patients. And reactive oxygen species, autophagic cleansing capacity declines gradually, and dysfunctional proteins and mitochondrial accumulation leading to increased levels of ROS. Saccharification is one of the endogenous aging mechanism, and Alexandra have told us about it. And ROS causes oxidative stress and series of inflammatory reactions activated by inflammation, cytokines, DNA damage, and we have to stop it. Even in a woman who are 18 years of age with POI, or even in women who are 60 years of age. So we can do the same thing. Let's influence it. And in our study, we have 300 women with confirmed POI looking for being pregnant. And many doctors told them, your chance is 1%. Please don't try. It's not normal. You have just to take oocytes from donation. And all of them have a nice BMI. They are not obese one. And we have done all hormonal analyses and OGTT and proper statistics. And what can we see here in this very interesting table? All these hormones and area under the curve for glycemia and insulin. Before therapy, it's a typical for POI, so high gonadotropins, low estradiol, and high insulin area under the curve for a lean POI patients. At conception time, we can see sharply decrease of FSH to 21, LH to 13, estradiol increase, and of course, very statistically significant insulin area under the curve decrease at the time of conception in all that POI patient, not PCOS, POI. So the same situation like in PCOS, very interesting. But what about those who didn't conceive? Are there any differences? Yes? There are values of all these hormones, and insulin area under the curve is not so nice as of those of pregnancy rate. Let's say FSH in those who had conception failure is higher. So we didn't give them enough estradiol and enough Proxeed and other antioxidants between all other hormones and medications. And of course, insulin area under the curve is higher in those who fail to be pregnant. So, results. In our study, pregnancy rate is 15%, not 1%. Is it the same? No. So we can't do something. Please don't disappoint all these women. Please think about them. And let's try to do something even when it looks to us that it's impossible. Mean weight gain during their pregnancies is only 12 kilos, so they are not obese. They don't have diabetes during pregnancy, not eclampsia. Why? Because of the preparation at least 6 to 12 months before pregnancies. And mean baby born weight was 3,460 grams. So no diabetes, hypertension, preeclampsia, preterm birth, fetal growth abnormalities, fetal death, nothing. Why? Because of the preparation of all these women before pregnancy, and they all have POI, so we can do something. In conclusion, micronutrients have a special cofactor role in improving oocyte quality and endometrium receptivity in POI. But it's very important to give all those women appropriate estradiol levels, not like contraceptive values or like those in menopausal hormonal therapy. It has to be higher in order to reach FSH of 15 or below. The complex interplay between genetic, endocrine, psychological, immunological, hematological parameters need to be further clarified in order to reach the best therapeutical approach to women with premature ovarian insufficiency. And of course, this is my Belgrade dream team of young doctors. Half of them are here. They are PhD students and others. And Professor Genazzani, they will write all these papers for Graham and all other because their future and the best Europe has, because we are Europe, and that's it. And of course, che bellezza in Italia, che bella Italia, and arte in Italia. So let's enjoy in every moment, because it's a stressful, not stressful way of life, but let's fight against stressors with all medications, with smile, and believe in empathy, sensibility, love, and better living in this planet. Thank you very much for attention.
Thank you very much, Svetlana. Fantastic, fantastic. If we go back to our institution, if you have a patient with a POI, she's, I don't know, 32, 33, FSH of that size and so on, and we don't have any possibilities. We know that there are some spontaneous pregnancy coming if you give an adequate hormone replacement therapy with estradiol and progesterone, but this data seems to indicate that really POI, one of the causes of POI, in addition to many others, should be also the hypersensitivity of the individual to aggression of oxygen radicals in this individual. I think you fantastic lesson, fantastic lesson. A result of this one, 16% of pregnancy is something that we have never seen.
And nice numbers.
They have no possibility. You cannot treat with gonadotropies, with nothing.
No.
Thank you. Please, it's open for questions from the floor.
Comments,
and
questions.
Comments.
And in our database, we have 2,500 women in one small country. Serbia has 7 million people, so it's a small country, not like China or great numbers. But unfortunately, after bombing Belgrade in 1999, something changed. But it's not radiation, but stressful way of life later on. And then we have increase in POI. And then I was shocked, so many patients come to my office, what's going on? And then we have tried to collect them and, of course, to help them. Yes. And many of them don't like donation.
Yes, and I would like to ask you something. You have seen the results. What it was the mean duration of the treatment to achieve the changes in endocrine status? What it was in your group?
We tested all of them for these hormones, but many others, because I have to talk for a long time. But many of them have estradiol given for medication, 6 to 12 milligrams of estradiol valerate. It's normally 2 milligrams in everyday practice, in all other pills. But then we increase it depending of individual FSH. And then we are following them every 3 months. And we are looking for TSH. It has to be between 1 and 2.5. Every month we are following them if they are looking for a pregnancy, and then we add, if it's necessary, for subclinical hypothyroidism, a little bit of thyroxine. Then metformin, about 1,000 or 1,500, depending of the area under the curve. So it's not the same for all of them. And all of them has normal BMI. I underlined it because it's interesting. But if they are under stressful, or many people ask them, oh, when will you be pregnant? How long will you wait? They're under stress, and then alprazolam is very, very good in a very small amount. But just relax, who care about pregnancy, it'll be. And then go to sleep at 10 p.m. and take melatonin whenever it's possible. And please have 1 hour daily for yourself, for your needs. And per week, 1 day for going outside in the nature with your partner. And then during 1 month, a longer weekend, 3 days out of your town, and every 3 months, 10 days. So enjoy life, please. We have a science, but enjoy life. And pregnancy will be possible, because I like to speak with them and tell them that everything is possible. Who is that one who can tell it's impossible? Only if they don't have ovaries. Okay, I understand today if they don't have ovaries. But in all other situations, you don't know how many oocytes are present in such non-functional oocytes. Are they non-functional? I'm not quite sure. Today, really not.
Thank you. Please, Steve.
Svetlana, you said how many months did you treat some of these people? And in the failures, did you see any bleeding or any endometrial changes that you didn't want to see on that kind of a dose?
No, because it was just a normal cycles. We are following them up. And of course, at the time of the conception, the dip of endometrium is normal 8 to 9, or like in all others. But sometimes we took oocyte when it's mature, it's just one oocyte, make aspiration, and then we do IVFs. No problem, but just with that one oocyte, why not? Or we collect from 1 month to another, let's say 3 months, 4 months, and we take every month one oocyte, make IVF, then do embryo freezing, and later on we put it inside when endometrium will be receptive.
Individually?
No, they are bleeding every month normally. Yes. We had progesterone, estradiol, estradiol and progesterone, normal
Please, Nick.
cycles.
Well, the first thing to say is congratulations on the work that you're doing in this very important area.
Thank
and
you.
I look forward to our collaboration as well, and looking forward to our session tomorrow on POI. So with these high doses of estrogen that you're using, do you think their FSH receptors are down-regulated by the high FSH? So when you give that estrogen, it brings down the FSH, and it facilitates ovulation of the remaining follicles.
We've found that, really, even in a woman who had FSH 90. We were shocked, but it was possible. Of course, not for 1 month or 2. No. It was a longer therapy, but they have to take therapy, more or less. And in a longer period, we have a better success for some of them. But when we'll stop with all of that and tell them go for donation, if we reach FSH 10 to 15, and during 6 months no follicles who are growing up, then, okay, really the possibility of being pregnant is so low, so you can go for oocyte donation. But they change their minds because they see, okay, something's going wrong, I'll do it finally. So psychological moment is very important, and some secret details of that is that if they are under stressful conditions, FSH is higher for 10 international units. If they are relaxing, 10 lower, let's say 25 or 15, it's a difference. So
Guys,
we have to think about the way of life.
This is individualized medicine. Eh? You know, we need
Off-label,
individualized
off-label.
medicine. This is, please. Is your the last question and your answer, because we have the General Assembly after. Please, we enjoy.
I wanted to ask, what is the regime for the estradiol and then progesterone? How many days?
Let's say it's estradiol valerate, 21 days, with micronized progesterone for 10 days, and they are regular cycling women. But if we increase level of estradiol valerate, then we increase micronized progesterone as well. So sometimes it 200 milligrams of micronized progesterone in the second phase, or if there are higher dosages of estradiol valerate, then it is 400 milligrams of micronized progesterone.
Vaginally or orally?
Vaginally or orally, but sometimes during the day it's a problem because of dizziness, and it's much better intravaginally in the morning.
Thank you. Thank you very much,
you.
Svetlana. Fantastic. Hope, please, you see, we go from generalized to individualized medicine, and also the empathy is a fundamental part of our daily activity as doctor, the empathy and the contact with the patient.